I want you to move from overwhelmed by information to confident in what really matters. I want to help you move from being unsure towards direction and purpose in your healthcare. I want to introduce you to health experts. I want to let you in on tough conversations on women's health. I want to give you a place where you can lean in and learn how to take care of yourself. Let's transform your health. Let's get clear on your goals. This is Women's Health Unplugged. I'm your host, Dr. Jordan Robertson, naturopathic doctor. If you've been following along on the podcast, you know that I have a huge emphasis on helping women make great informed health choices. And this often brings up the question about whether or not screening tests should be employed as part of a woman's journey into understanding her health in order for us to better support her. I'm Dr. Jordan Robertson, and I'm the host of Women's Health Unplugged. And in this episode, we're going to dive deep on the recommendations for screening for cervical cancer so that you can make an informed decision about whether or not it's ready for you to enter into a screening program, depending on where you live. It's interesting because for most screening tests, I'm quite an advocate for. And when women come to me, part of my screening process with them is to understand where they are at as far as being up to date or not that up to date on the general screening tests that we recommend that women or people of all genders have in order to help us better understand their health, right? So this could look like things like, regular screening for blood in the stool for colon cancer, screening for cholesterol levels to be elevated, screening for thyroid, screening for vitamin D deficiency, which we've talked about on the podcast before, or screening for breast cancer. And so regular screening programs really have become a way for us to help predict who's at risk for a particular disease. And we want to offer these screening tests at a time where we can have a massive difference on those patients if we happened to identify them or find this disease in question at a stage where we can actually change what's going on with them. Perhaps related to sort of the highly sexualized nature of this conversation, has actually not adopted the screening schedule that is best supported by evidence in the literature. So we're going to talk about that and how basically what the evidence is suggesting for cervical cancer and cervical dysplasia screening, and then what various countries have adopted as far as their techniques and their schedule for putting women through routine cervical screening. And that's going to let you make a bit more of an informed decision about whether or not you qualify for having cervical screening and how often you should go. So maybe you're a woman who does identify as needing to go for cervical screening, but the interval between your pap tests is actually longer than what's recommended. Whether or not you want to have cervical cancer screening or not, I think this is a really valuable understanding lesson for us to go through so that you can see where you fall as far as who benefits and who does not benefit from regular cervical screening. So I want to lay some kind of ground rules as far as having this conversation before we dive in so that you understand who I'm talking about and what sort of the purpose of this conversation is. So when we talk about testing, we're typically talking about diagnostics, right? So when we talk about, are there blood tests for PMS? No. Are there blood tests for anemia? Yes, right? When we're talking about blood work, and often our conversations about blood work on the podcast have mostly been about diagnostic testing. And that's different than screening testing. So screening is actually about prediction of the future. It's not about diagnosing what is. And that means that our tolerance for doing a test or our interest in doing a test actually needs to shift a little bit. Because if we're going to, at a population level, put many, many, many people through a particular test, we need to be sure that the results that we get back are something that are kind of important. And I think this is important to spend time on, even though I get that this is much more of like the geeky research side of this topic. But I recall when the mammogram recommendations changed at one time in Canada, where they actually decreased the number of mammograms that women were getting women were up in arms thinking that the government was trying to save money by doing less mammograms. And actually, funnily, the research shows that if we change screening guidelines, that patients' perception is that this change in screening guidelines is as a cost-saving measure, where that is rarely the driving reason why we would change a screening test or why we would change the interval between a screening test. It often has more to do with what we think we are or aren't getting back from that particular test. So when we're going to try and do a test like many years in the past in order to predict a disease that's coming in the future, it has to do a couple of things, right? It has to be a significant public health problem, right? If something is showing up, 1 in 1 million people, putting everyone through that test is not a very good use of time and resources, and it probably brings up sort of false flagged people. And this is what we were finding with the mammograms is the more people who had mammograms, the more women who had biopsies, and not enough of those biopsies were giving us, solid answers. It meant that many, many women were having unnecessary surgeries, unnecessary biopsies. So just like this, if we have a condition that's very, very low prevalence in the population, having every single person be screened for that disease may not be a worthwhile endeavor, but it also means that we're probably collecting a lot of people who are accidentally flagged for that disease who truly don't have it, right? Because with every test, there is some level of error where maybe we're accidentally flagging people instead of truly flagging people. So we want to screen for something that's actually a relevant public health problem. And we also want to screen for diseases that either have readily available treatment, right? So we don't want to look for it if we can't do anything about it. Or, for example, if it's contagious, right? So something where there's community transmission, and we would love to be able to find it and stop it, even if it is something that we can't cure, like HIV, right? The test also must be able to detect the patient before things get too bad, right? Like we want to be able to find it at the right time. So screening for something that's already well into the disease process that's more like a diagnostic test, right? That's not really screening. It also has to be safe, right? So the test itself has to be safe, has to be a reasonable cost, healthcare cost, and it has to actually demonstrate to improve health outcomes. And so this is, again, this sort of mammogram conversation. We weren't helping any more women by screening women more often. So at the end of the line, it didn't mean that less people died from breast cancer when we were screening women every year. But what it did do is meant that many women were having unnecessary biopsies, etc., but no more women were saved. And so the screening actually needs to help decrease whatever our outcome is that we're trying to track, right? So if we come back to that cervical dysplasia or cervical screening, we're trying to reduce the deaths from cervical cancer. And we do know that if women have Pap tests, that we do change the outcome of women actually dying from cervical cancer. But lots of those other questions, right? When are we detecting it in the course of a woman's life? Do we have readily available treatment, or does treatment need to be applied, et cetera, et cetera? These are the parts of those questions that need to be answered with cervical testing and Pap testing, and we're not always meeting all of those guidelines. The other thing is that, when women get flagged for any kind of condition, right, through screening process, it generally increases the nature of the screening that they start to move through, or they have more invasive procedures in order to confirm the diagnosis. So my mammogram to biopsy example is a good one there. But for cervical dysplasia, the treatment or the way that women move through their process actually does carry some risk with it. So when women have either a LEEP procedure or surgical excision of their cervix, they actually are having some negative consequences. So when we start to screen for a disease, we need to balance all of those things, right? We need to make sure that this is a big public health problem, that we can catch it at the right time, that it's safe to do the screening test, that it's reasonable cost, and that it's actually changing our outcome, which is the number of women who die from cervical cancer or suffer, significant loss of life, loss of quality of life from having cervical cancer, even if they don't happen to die from cervical cancer. Certainly, the treatments associated with cervical cancer carry with them their own challenges if women go on to live beyond their cervical cancer. So these are all of the considerations that we're kind of throwing into the big pot to make a decision about whether or not we should do any kind of screening at all. So I want to start the conversation by saying that screening tests are different. They're not just diagnostic tests. Because that kind of leads us into that second part of the conversation. We all know a woman who has had a young diagnosis of cervical cancer and perhaps has died from cervical cancer at a young age. And I'm not exactly talking about that woman, even though I know those women, I've worked with those women, and I've treated those women. I'm not exactly talking about those women. So they are the outliers for the most part on the statistics when we're talking about cervical cancer. They're the ones that were the 1 in a million that were caught by early cervical testing and maybe greatly benefited from their having routine screening done at a very young age, which I'm about to make the argument that doing screening at a very young age is not necessary. Not really talking about those women, and that's not to exclude them. It's to remind us that sometimes when we know or can recall a particularly unique scenario or case, that starts to make us feel like we should do screening all the time in everyone, right? Because we can see right in front of us that there is a young woman who at 21 had a rare type of cervical cancer that either, thank God, she was caught on early routine screening, or she should have had early routine screening. And that can make us in favor of routine screening, right? I hope you're following me here. The emotion of us seeing some of those cases in our face can make us feel that routine screening is something that we should never cut corners on, that we should always be doing. And if a pap test is available to us, why wouldn't we always do a pap test, right? And so I'm not really talking about those specific unique cases. I'm talking about the population at large, and we're going to talk about when we maybe should or shouldn't deviate from those screening recommendations that I'm going to discuss. When we're talking about screening, we're talking about doing it to everyone, right? And so those unique cases with rare types and rare presentations and rare age of onset, they fall outside of those population statistics that we should make decisions about. We shouldn't give every 18-year-old woman in Canada a pap test because one time one woman died of cervical cancer at 18. And I recognize that does sound a little bit insensitive, but we're talking about population statistics in this moment. I'm not talking about the individual case. And that woman would have benefited greatly from her early screening, but she's the one that would have benefited, right? And when we start to talk about not just the healthcare cost, but also the person cost and the side effects of doing frequent and early cervical cancer screening for women, you'll see that when we look at population-wise, this is actually not the recommendation that we should be making across the board. The third point I want to make before we dive in is that this conversation around cervical health also includes transgender men. So transgender men who still have a cervix actually should follow exactly the same guidelines as cis women when it comes to cervical cancer screening. However, they are often under-screened, with very few transgender men being part of a routine screening program that actually helps them identify and be treated for cervical dysplasia or cervical cancer. So even the Canadian Cancer Society identifies that they don't have the evidence for deviating from the current recommendations, which means that the recommendations should be exactly the same as cis women. So this conversation that we're going to have for the rest of the podcast applies to all people who have a cervix. So whether you identify as male or identify as female, if you have a cervix, these recommendations are exactly the same. The unique part about the transgender population for transgender men and cervical health is that that population appears to be at higher risk of having a greater likelihood of cervical dysplasia, but they also are underassessed. And I can't separate those two things out. I can't tell you why they have a higher percentage of cervical dysplasia. And we'll talk about what all those risk factors are. So maybe there is something else that, goes along with that population of people that's going to make them a higher risk category, whether it's HPV, whether it's smoking, I can't tell you. But what I can tell you is that there's a combination there of a higher risk of dysplasia and a lower likelihood of actually engaging in routine screening, which is a public health problem, right? Because of how effective cervical screening can be once you are supposed to enter that screening program. So the rest of the podcast is going to be talking about all people who have a cervix, and it applies both to transgender men and to cis women. So back in the day, we used to do cervical screening for women sort of in a more opportunistic way. The guidelines were a little bit made up. We either did it on a woman's 18th birthday, we did it after her first experience of sexual intercourse, or we did a pap test when she asked for an oral contraceptive. And those guidelines, meant that women started kind of at various ages. And it also made those things linked with whether or not you should have cervical testing done or not, whether or not, regardless of what your age was. So if you became sexually active at 15, the recommendation was to have a pap test. If you were not sexually active and you got all the way to 18 or 19, it meant you had to have a pap test. And if you were using the oral contraceptive pill for a reason other than contraception, it meant that you also started to get routine and often annual cervical screening, whether or not you were, sexually active, right? So those kind of it's called opportunistic screening, where rather than being on any kind of regular schedule or routine, they used some other opportunity to apply the screen. Right. So as you can imagine, there's lots of women that are going to get captured into this very early screening technique, if we use that as a technique. And we're going to end up screening lots of women at kind of a young age, right? Maybe pre-18. But it also means if those women don't go to the doctor for any of those particular things, that they are not going to be screened. So let's say a woman gets put on oral contraceptive at 16, has a pap test at 16, is sexually active for a period of time, but then, either abstains from sex or something changes where she no longer returns for that prescription. If we were using that as an opportunity for her to be screened, now she's just not being screened for this random amount of time until she again returns to the doctor for an exam or to ask for another prescription of oral contraception. So it's creating this mishmash as far as recommendations if we're only using those kinds of opportunities to initiate when women should be screened. And it's putting a lot of emphasis on her sexual health and sexual history as being the basis for when we decide whether or not we're going to do cervical testing, which is a little bit true as far as what we should think about whether or not women are candidates for routine screening, but it's not the sole thing that we should be kind of looking out for when we're making a decision about screening. So it often, or it sort of, it arbitrarily kind of joins those two things, like first sexual encounter and cervical screening, versus us having a little bit more of an evidence-based approach for when women should be checked. So that sort of opportunistic screening was employed through much of Canada and the United States and even in Europe. And then they were giving it was pap tests annually. So again, it was often as a opportunistic screen where when you returned for a prescription renewal or when you returned for a physical exam annually, women were screened every single year if they went back to the doctor after that time of that first pap test. So you can see in a woman's lifetime, let's say she became sexually active at 16, asked for an oral contraceptive. She's potentially having annual exams from 16 onwards. And we're going to talk about in a second that that's not actually an appropriate approach, but that's having many, many, many pap tests before a woman's 30th birthday. Now, HPV is responsible for almost 100% of cervical dysplasia. So what we mean by that is that it is absolutely necessary to have an HPV infection But it's not sufficient. So HPV on its own doesn't lead to cervical dysplasia. It means that it has to be there, but often other components of a woman's health, whether that's her smoking status, whether that's maybe co-infection with another STI, whether that's being on an oral contraceptive, which the hormones in an oral contraceptive increase your risk of cervical dysplasia if you have HPV. So there has to be some other piece of the puzzle that actually means that that HPV is going to cause enough disruption that a woman has cervical dysplasia. Now, under the age of 30, most women have at least one strain of HPV infection at one point in time in their life. The unique thing is that women under 30 also may have the sort of immune system robustness to actually clear that infection. So where women may have been flagged for having dysplasia at one time, they may naturally, like the natural course of the infection is that woman can clear her cervical dysplasia without treatment, right? So if a woman tests positive for HPV and mild cervical dysplasia at 22, she may actually clear the infection on her own. There's actually quite a high likelihood that she would clear the infection on her own by her 23rd or 24th birthday. There are very few HPV strains that actually do have that high predilection for causing cancer. And with the routine vaccination program, at least in Canada, that entire population of young women who were part of that initial vaccine campaign, they actually turned 27 this year, 2021. And so they're coming up to the age where we're going to see we should see a dramatic reduction in the number of HPV infections because we're seeing this collision of, women who had been vaccinated also reaching the time where we would start to be concerned about women having cervical dysplasia. So even though HPV is responsible for a huge percentage of dysplasia, or it's responsible for about 100%, most women can clear the various types of HPV without suffering any consequences of it. But also, if women do get an infection with an HPV strain that does have that pro-cancer impact, it can take up to 10 years for that infection to translate into an actual carcinoma in those patients. So remembering back to the beginning of the episode when I said that screening needs to be done in a way that actually catches a condition at the right time, there's actually quite a span between when a woman is initially infected with a cancer-causing HPV and that time where that infection would actually start to turn into cervical dysplasia or become a greater problem with cervical cancer. So when we start to mash all of this together, like I said earlier in the podcast, we're starting to mash all these things together and say the timing, the cost, does it catch things at the right time? Is it catching anything at all, right? So back to my 22-year-old who now suddenly, her HPV infection clears up because she's a healthy young woman. By screening all of these women all the time, right? So go back to our 16-year-old woman who asks for oral contraceptives, and now she is getting pap tested every year. There's going to be moments that we catch a transient HPV infection that she would otherwise just get rid of on her own, right? And often once we've found a cervical swab that's actually positive, women get screened more often, right? They get screened again in 6 months and then maybe again in 6 months. And so there were many times where we're screening women and finding things that were perhaps of no long-term consequence, right? Because we're screening women at a young age. We're screening them opportunistically, right? Just because they're there and they're asking for a prescription. And now we're finding something that would go away on its own, even if we didn't do anything. And if it was something that was more sinister, it could take up to 10 years for that to actually translate into something worthwhile of finding in that particular patient. So hopefully you're starting to see, right? I'm sure at the beginning when you hear me say, okay, less pap tests is better, right? That raises your eyebrows going, what, is she crazy? Pap tests are good. And I'm not saying they're not good, but I'm saying we have to be strategic about the way that we bring them into a woman's health plan so that we don't have consequence. So the other half of this conversation is the why wouldn't we, right? Why wouldn't we have that young woman go for a pap test every single year? right? What's the harm in having her go for a pap test every single year? Well, interestingly, there is harm. So we know that when women go through treatment for cervical dysplasia, or if women have cervical dysplasia, that they actually have an increased risk of preterm labor. So there was a great review article done in 2016, which I'll post the link in the show notes, that looked at over 6 million women who had gone through screening or regular screening for cervical dysplasia. And they tracked women who had no dysplasia, and then they tracked women who had dysplasia. And then they tracked all of those women who had dysplasia to find out what kind of treatment they were offered, right? So they would have had cervical biopsy, they would have had some tissue removal, some of them would have had a LEEP procedure, some of them would have had some cauterization of that tissue. And what they found is that there was nearly a doubling of preterm labor in subsequent pregnancies. So these weren't women who were pregnant. These were just 6 million women who were young and who had cervical dysplasia. But when those women went on to have pregnancies and became pregnant, it nearly doubled their risk of preterm labor. So if you're following along with me, we have the 16-year-old who's now being screened annually. We have our 22-year-old who has HPV infection that she maybe would have cleared up on her own, who are now being screened really frequently, who are now finding things in, and we're probably treating them, right? And this young group of women who are being treated for their cervical dysplasia in the future are increasing their risk of preterm labor when perhaps all the things that we would have found in them would have maybe turned into nothing, or they would have actually cleared on their own if they had a healthy, robust immune system, quit smoking, were treated for their other STIs, and all of the things that go along with increasing that risk of cervical dysplasia. So you can see why this early screening is now becoming a problem, because the treatment or the path that they head down when they get flagged is not completely benign, right? It's not completely without harm. So just like the women where, we put them through mammogram, we see something, we biopsy it, and we say, oh, sorry, there was nothing there. Some women will have, consequences from that, right? Maybe they have some nerve pain after their biopsy. Maybe they get some swelling after their biopsy. Maybe they all just have like emotional trauma after their biopsy. So there's harm associated with that. And I think we've undervalued the importance of the harm associated with treating cervical dysplasia because we kind of assume it's no big deal, right? We assume that we should go for all the screening all the time, and that if you do get flagged, it's really important, right? Oh, they found something on my cervix. Now we're going to monitor it super closely, and now we're going to treat it, right? If we can't have it go away on its own, we're going to do something. And so in those 6 million cases that were compared against women who were never had cervical dysplasia, any kind of treatment whatsoever increased their risk of preterm labor. Now, remembering the population we're working with, this is important. So if we were increasing preterm labor in women who were 40 to 45, I don't think we'd care, right? Like the percentage of women who are between 40 and 55 who are going to have a baby is relatively low. But the population that we're screening often, or that we're finding things in often, even if it was going to go away on its own, and that we're putting through a treatment process, how old are they? They're 20 to 35, right? They're the group of women who care if they have preterm labor or that their risk of preterm labor is literally doubled. And so now we really have to ask ourselves whether or not we're causing less harm by doing nothing or causing less harm by screening. It's a very important question. So it's actually such an important question that we had an entire task force in Canada actually make recommendations on whether or not what we were doing for cervical screening was actually valuable. And so the Canadian Task Force for Preventive Health Care, which this is a group, it's an independent group that analyzes all screening at a public health level to figure out exactly that question we're trying to answer. Like, when do we start? Who does it benefit? Does the benefits outweigh the risks? Can we find these issues at a time that we can actually make a difference in these patients? These are all the things that make up a good screening test. And they actually suggested that we should make some changes based on what the screening should be. So basically, and this paper is widely available to be read, and actually the Canadian physicians have started to make recommendations about this as well, and made some lobbying efforts to the provinces to make changes for the cervical screening guidelines. So basically what they found is that there's no evidence for screening under 20 years of age. Although interestingly, they sampled a whole group of women in Alberta, and 42% of them had a pap test between 18 and 19. And this was done at this within the period of time that they were making the recommendations. So about half of women are having pap tests under the age of 20, even though there's literally no evidence for screening women under 20 at all. 10% of those women who get screened under 20 get sent for colposcopy, which a colposcopy is like one step above a pap test, where they can actually do a closer exam of the cervix, and often when they take a small sample of the cervix. And this is exactly what we're trying to avoid, is having women be escalated in the kind of testing and procedures that they have when it's not necessary. So half of women under 20 in Alberta had a pap test, and 10% of them were basically up-leveled into more aggressive screening and testing for their cervical dysplasia. So the big question is, if we changed those numbers, meaning that we didn't screen any of those women, was there going to be any change in the amount of cervical cancer that those women get, right? So remember back at the beginning, I said we're trying not to talk about the outliers. So interestingly, even in that same age group, so if we stop screening women under 20, what happens to cervical cancer mortality in women who are 20 to 25, right? If we stop looking, what happens? There's literally been no change in mortality from cervical cancer since the 1970s in women in that age group. So what that means is women who do get cervical cancer in that age group, we're not any better at treating them. But we're also not any worse at treating them either, because we didn't look. And so if we change our screening guidelines, it's not actually changing our outcome, which is the most important thing, right? And so it's actually very strongly recommended against screening women under the age of 20 at all. 20 to 24, they also recommend that this group of women, there is not sufficient evidence for them to be routinely screened in that age group either. And so we're seeing that there's a whole group of women, by example of a woman going to her doctor for contraception at 16 up to age 24 who shouldn't be screened at all, right? We literally have no evidence that we're going to change outcome by having those women screened. And as you could see, a percentage of those women are getting sent off for more invasive screening and biopsies. And that actually is where we start to see the risk coming into play. There is great evidence for screening women 30 years and over, and that screening interval should be every 3 years. So there are some countries that use every 5 years, and that is not as effective as being screened every 3 years. So regardless of which country you live in, and regardless of actually what their current strategy is, if you're trying to reduce your risk of cervical cancer, the very best interval between your PAPs is 3 years, okay? And that's for women over 30, and that takes you all the way up to age 70. After age 70, women can stop doing routine cervical cancer screening if they've had negative tests the last few times that they've gone. And if they haven't done routine screening, then we kind of recommend them having 3 tests in a row that are negative. And once that's happened, then they can, graduate and no longer have cervical screening done. And that's kind of what the recommendations suggest. When we start at 30 and we move forward, doing it every 3 years catches enough the women, it catches the right women, it catches them at the right time so that we can have impact, and it doesn't put as many women through unnecessary treatments like biopsies and whatnot. Now, if you're in your 30s and you're trying to get pregnant, this is going to raise some questions as to whether or not you want to escalate through that process. And that's a different maybe conversation. But it's the actual pap test that there's evidence that you should go for. It's do we want people cutting a piece of your cervix off to test it? That's where we'd probably have to make a unique decision based on what we thought your individual risks were. Right? And so, but over 30, the recommendation should be every 3-year interval to go for cervical screening. Now, if you've noticed, I've strategically left out the age group between 25 and 30. And that's partly because this is where it, in air quotes, depends whether or not we want to employ routine screening. Now, when we're talking about a 5-year age gap, and we're also talking about most countries doing 3 to 5 year gaps between pap tests, we're probably talking about the additional 1, maybe 2 maximum pap tests in that period of time for women. However, I do think based on, all the things that we just talked about, there maybe are some times where women would choose to be tested in that window of their life and women who would choose not to be tested in that same window. The task force is really clear about there being zero evidence for testing under the age of 24. But then they flip and say that there is very, very weak evidence to test women between 25 and 30 and go on to make the recommendation that we keep those tests and that we do them every 3 years. This is where I would want women to make kind of an informed decision about what they think is important and have a really good conversation with their healthcare provider versus that like opportunistic screening, like, well, you're here, so you might as well, right? In this age group, it might be worthwhile just to have that simple first pap test done, but the conversation would certainly have to change or at least be more in depth if we're going to start talking about biopsies and LEEP procedures if women happen to get flagged for cervical dysplasia. Because like I said, like lots of women are going to have that infection clear under the age of 30 and it never be of any consequence. That's a conversation you're going to want to have with your practitioner about what the specific pros and cons are of doing testing in that group. And like I said, it's going to be interesting to see what happens when the young women who've been vaccinated reach this age group, because we may actually need to do less screening because we've, effectively decreased the number of concerning HPV infections. Now, in this age group, and really in all age groups, we may want to shift our suggestions based on those other risk factors that women have that may increase their risk. So women who had their first sexual encounter at a very young age, which in the research was kind of defined as under 15, women who have had multiple sexual partners, women who've had co-infections with other STIs or bacterial vaginosis, women who smoke, or women who've been on an oral contraceptive, that actually heightens the risk. And so if those things are prevalent in a woman who's 24, then I think she's a really good candidate for having cervical dysplasia screening done, because it's increasing the likelihood that she's going to have more significant cervical dysplasia. Even if we do find it, the grading of it might be higher than a woman who has had a low number of sexual partners. They defined that as over 6 in the research. So that was kind of their cutoff for many, high degree of sexual partners versus low. But if women started to have these other things in their case, I would maybe make an argument that we do want to screen women earlier. And if a woman is 22 and has a lot of these risk factors, then she probably also should be screened early, even though the current recommendations is that by and large, we don't want to screen women at a young age. You have to remember, like we said, like these are public health recommendations. We can always find that one woman who probably needs to deviate from these suggestions. And then women who also have other conditions that might make them immunocompromised. So if they're HIV positive, or if they take medications that suppress their immune system, like if they have an autoimmune disease, then the likelihood of that HPV infection being cleared on its own, which is what we're kind of, leaning on in the group under 30, then again, you probably want to be screened more often, right? Because your particular health case is different than us looking at things from a population level. So this Canadian task force made these recommendations, and they actually made them in the early sort of like 2013, 2014 period of time. And since then, quite a few special interest groups like the Canadian Medical Association Journal have reflected on the recommendations made in that task force to see if any of the provinces have actually followed through and changed their recommendations. So as of 2019, the Canadian Medical Association Journal actually reflected on those recommendations and found that only 2 provinces had changed their screening guidelines to stop screening women under age 25. And interestingly, from the time that that task force paper was written, which was 2013 to 2019, there had been no changes to cervical cancer rates. So even though they were screening people like crazy, they weren't doing any better at decreasing the prevalence of cervical cancer. Whereas if we thought that like screening all the time was going to make big differences, we should have maybe seen a reduction in the number of cancer cases. And in those two provinces who changed their recommendations, they did not have an increase in cancer cases or deaths from cervical cancer. And so their recommendation, the Canadian Medical Association Journal, was that the provinces need to do a better job of changing the population screening and to communicate that with their population of physicians so that women are offered cervical cancer screening and cervical dysplasia screening at the appropriate time, and to educate women about why those changes need to be made. Like I said at the beginning, often when we make a change to public health that includes less poking and prodding, women think we're doing that because of a cost-saving measure. They don't realize that we actually have learned something that either teaches us that the screening is not as important to do it as frequently as we once thought, or that screening actually puts women at risk, right? When we look for things, we find things. And when we find things, we do things. When we do things, we cause side effects or challenges. And this is a perfect example of that. Lots of young women going for lots of PAPs finds lots of cervical dysplasia that gets lots of LEEP procedures, which doubles our risk for preterm birth. So this is a really important conversation that we have with this younger generation of women coming up so that they know when to be screened and they're screened at the appropriate time. I mean, beyond that, there is a massive healthcare cost of doing all of these tests. There was a simulation, it's called OncoSim, and they did a model or sort of a modeling to figure out what the cumulative costs were for testing women between 21 and 25, which is that age group that we're suggesting that we stop testing. And starting at age 21 instead of 25 meant that they were doing 163,000 more pap tests per year in Canada and 15,000 more colposcopies, which is that like escalated version of the pap test, which often involves some tissue removal. And so you can see like that's a huge number of tests being done in an age group that actually, we know is not going to change outcomes, or it's not going to help us if we test all of them. And the annual cost is $30 million per year to start screening at age 21. And so the amount of healthcare costs that's going towards screening women who don't actually benefit from having cervical screening done is monumental. So even if we just wanted to look at it from a cost-saving perspective, that's a tremendous amount of money that we spend on a screening test that maybe isn't helpful at all. So what I want you to take away from this episode is if you have a cervix, at some point it needs to be screened. And starting at age 30, that screening interval should be every 3 years, and that is highly evidence-based. So when you get that letter in the mail from the, cervical cancer screening guidelines and says you haven't been for 3 years, don't procrastinate and book an appointment. If you're over the age of 30, that is absolutely the best way to be screened for cervical dysplasia and cancer, and it tremendously decreases your likelihood of having cervical cancer. If you're under the age of 30, we need to start to ask ourselves some questions about whether or not it's appropriate for you to be screened. Under age 24, the Canadian Task Force for Preventive Care actually suggests that there's no evidence for screening you. You have a high likelihood of improving your own HPV infection, especially if you eliminate some of those other cofactors like smoking and other STIs. If you're between the age of 24 and 30, then probably you should have at least one test done in that span of 5 years. But you do have to ask some questions before you start to get escalated down the path of perhaps having your cervix tampered with. Any tampering with the cervix appears to double the preterm birth rate in women who've had any kind of cervical dysplasia that then was treated compared to women who didn't have dysplasia at all. And so in that age group, we're now seeing this intersection between the time when women are most likely to be trying to get pregnant and women who are being screened that maybe don't need to be screened. And so we have to make sure that we're always asking the question about whether or not the test and the procedures that we're putting you through are in your big picture best health interest. Finding HPV or finding cervical dysplasia at that moment may not have a big long-term impact, but doubling your risk of preterm labor does. I hope you enjoyed that conversation. And then it sheds a little bit more light on the whole concept of screening tests in general. And of course, talk to your practitioner, but it's important that you bring up that, especially if they're looking at these opportunistic screening for a prescription renewal or whatnot, that you are following those guidelines that are recommended, because anything outside of that is a little bit less than, the best solid evidence. I hope you enjoyed that episode of Women's Health Unplugged. It's my absolute passion to bring women quality and science-informed information about their health so that they can make empowered, good decisions about their health care. I'd like to invite you to join me in my Facebook community, Women's Health Unplugged. There we share live videos, blog posts, and behind-the-scenes information about the podcast, where you can connect with me and other women who are interested in their health care. You can find us at facebook.com/groups/WH Unplugged. We'll see you there.